You're at Tatos. So today we're going to learn about liver pathology. We're going to start in the usual way by thinking about the pathology of the liver that you've already learned in ELM, and then move on to some new things. What do we need to know in liver pathology? So the core conditions on the left here are what are listed in the curriculum map. Some of these will be familiar to you and others will be less familiar to you. The first three you've probably covered before in ELM. We're going to revise those briefly and then introduce some new topics. In particular, in EM, you were introduced to the clinical and pathological features of acute and chronic viral hepatitis, the effect of alcohol on the liver, and the clinical and pathological features of liver cirrhosis. What we're going to cover today is we're going to revise some of the things from ELM using the slides from ELM, and we are then going to carry on with some new ideas. Okay, so remember, just look at the notes from ELM. There's lots more detail there. And the first thing that we're going to revise is the structure of the liver. So remember the acinus, there's a central vein, and then zones 3, 2, and 1 with different metabolic functions. And zone 3 is the most vulnerable to low oxygen. There's a portal tract with a portal vein, hepatic artery, and bile duct. And when we look at this down the microscope, here we can see the portal tract, the central vein, and zones 3, 2, and 1. In the liver, there are various cells. There are the hepatocytes, and between them are the little bile canaliculi. So the bile canaliculi will drain into the tiny bile canals between the cells and then head off towards the portal tract. Other cells that are in the liver are here. This is the sinusoid where the blood is. We've got lined by endothelial cells, these macrophages that we call Kupffer cells, and these stellate cells, which are the resting cells, which are called stellate cells when they're resting, but what they do is they produce collagen and proliferate when the liver is injured. This is a space of Dees. Okay, what's next? Let's think about this flow. So normally we think of the blood, which flows from the portal venule through to the central vein. But then there's a flow of bile that goes backwards into the portal tract, down the bile ducts, and of course into the gallbladder. Moving on to our first topic, liver injury. So liver injury can be caused by multiple things because of its multiple functions and its unique anatomy. So the liver's multiple functions, toxin metabolism, bile production, protein secretion, ammonia, homeostasis, means that it is vulnerable to a very wide range of insults. First thing is we're going to think about is what happens in acute injury from any cause, viral causes as well as toxins. You get these 5 things happening. The cells swell, right? So they're injured, so their ATP and membrane control doesn't work so well. They swell. The lipid metabolism is upset, so they don't export lipid, and it accumulates in the cells, so you get fat in the cells. Ballooning degeneration is a kind of change that we get with hepatocyte swelling, where all the cytoskeletal proteins, they just start looking fluffy on the inside. Then, of course, the cells can die, undergo apoptosis. As they swell, they block off the little bile ductules between each of the cells, and that causes cholestasis. And of course, this is going to be a conjugated jaundice because the cells have already processed the bilirubin, but sometimes the upset of the cells means that the bilirubin is not processed properly, so you can get a mixed picture of conjugated and unconjugated bilirubinemia. Let's have a look at this picture. Right, so here we have the cells that are swelling here, okay, swelling, and so we accumulate fat, we block off the bile canaliculi, we accumulate bile in the cells, and the cells can die with apoptosis. This is what we're seeing here. Here, so these cells are swelling. They've got bits of bile pigment in them. Here we've got big blobs of bile in the bile canaliculi. So the most common cause of acute injury are toxins and viruses, and toxins, of course, includes alcohol. And this is where we start thinking about liver enzymes and its relationship to liver injury. So liver enzymes are released from the dying hepatocytes, which explains the massive rise in transaminases. So I know that you've had your liver enzymes lecture. And I also know that you know the difference between ALT and ALP. Of course, the ALP indicating that there is more problems with bile duct occlusion. Okay. So the ALT and AST rise very high during acute injury and then fall if it moves into chronicity and it heals. There are lots of hepatitis viruses. Lots of things cause hepatitis. These are just the ones named hepatitis. But of course, other things can cause hepatitis, like Epstein-Barr virus can cause hepatitis. All viruses, all the hepatitis viruses can cause acute injury, every single one of them. Some of them it's transient and they go away, like hepatitis A. Hepatitis B can go through an acute phase, but then can settle down into a chronic phase. The same with hepatitis C. This is a diagram of acute viral hepatitis. So as well as the chronic cell swelling, bile accumulation, fat accumulation, what you get is inflammatory cells, right? So we get inflammatory cells in the liver parenchyma and inflammatory cells in the bile duct. Most of the problems in acute hepatitis occur here in the parenchyma. If it's really bad, we can get acute massive necrosis or submassive necrosis, where the liver just dies. So all this yellow bit is dying liver. And it's usually something bad like paracetamol that leads to this. But also it can sometimes happen with viral infections. So we know that acute infections can give, acute liver injury plus inflammatory infiltrate. But some infections go on to chronic hepatitis, and it depends on the type of virus. And hepatitis C is our worst offender. Hepatitis B is also bad. Hepatitis A does not go on to chronic infection. So here we go. This is what hepatitis B often does. We've got an acute infection leading to acute hepatitis, which can lead to subclinical disease in many people. They don't know they have hepatitis B. Think of all the children who have acquired hepatitis B at a very young age. They often don't show that they have hepatitis B because they don't become jaundiced. Only about 30% of people will become jaundiced. More than 90% recover. Some go on to this fulminant hepatitis. That's that, massive or submassive hepatitis, and others move on to chronic hepatitis, which some spontaneously recover. Some are in a carrier state where the liver doesn't become cirrhotic, and some go on to liver cirrhosis and get complications such as hepatocellular carcinoma. What are the key words for chronic injury in the liver? These are them. Interface hepatitis, which is the same as piecemeal necrosis, fibrosis, regeneration, and cirrhosis. Let's have a look at the picture. So in chronic hepatitis, the main action is happening in the portal tract. You do get very small amounts of inflammatory cells here in the parenchyma, But mainly what's happening is you get portal tract inflammation. The portal tract expands because the inflammation is predominantly around the interface here. This is why it's called interface hepatitis. It's on the portal plate here at the interface between the parenchyma and the portal tract. And these cells just here undergo apoptosis and die and are replaced by fibrous tissue. Replaced, we start getting an expansion of the portal tract, and these little arms of fibrous tissue reaching out until they reach the central vein and form bridging fibrosis. If enough bridging fibrosis happens, then the liver becomes cirrhotic. Let's have a look at the picture in real life. So this is the liver parenchyma. This is the expanded portal tract with the ducts. And here we have all the inflammation which is clustered around the edge of the parenchyma and portal tract at the interface. That's why it's called interface hepatitis. It knocks off these liver cells by T cells surrounding them one at a time. It's happening here, and then sending cytokines that make them have apoptosis. This is why it's called piecemeal necrosis, because one piece at a time gets nibbled away. Why do we get fibrosis as a consequence of chronic hepatitis? This is the normal liver that I showed you before. We get fibrosis because of replication of these stellate cells. The sequence is that the Kupffer cell, which is a macrophage and just adores releasing cytokines, does just that. It activates these stellate cells and also causes hepatocyte dysfunction and death. So the hepatocytes die and get replaced by the stellate cells. Okay, so we've talked about patterns of liver injury. In particular, we've talked about acute and chronic hepatitis and viral hepatitis. We're going to go on and talk about the rest in just a moment. But first, understanding liver enzymes. So key to understanding the liver is understanding liver enzymes. I do know that you have had a lecture at the beginning of 2024 on liver enzymes. If you're watching this in 2025, you will get a lecture, but it's just not quite there yet. So let's just have a look. This is my favorite resource, Geeky Medics, Interpretation of Liver Function Tests. Here's some top tips if you haven't had them already, and I know that you probably have. What we have to do is look at the ALT to ALP rise. So the ALP indicates duct problems, and the ALT indicates hepatocellular problems. They often both go up, but it's about the ratio of the ALT to ALP. So if the ALT increases more than 10 times, and there's less than a threefold increase in ALP, think of the liver cells, hepatocellular injury. If it's the other way around and the ALT isn't raised so much and the ALP is up, then it's cholestasis. If they're both up, then it is a mixed picture. ALP rise without GGT can occur in bone pathology because the ALP can come from other places other than the liver. I also want to introduce you to this key reference, which is from BPAC, another great resource for knowing about diseases. And this here talks about the AST and ALT ratio, because this can provide information on the cause and stage of chronic liver disease. So AST less than ALT can indicate chronic hepatitis B or C, or a steatosis type disease. Right, AST is greater than ALT, alcohol, drugs, cirrhosis, primary liver cancer. And if there's an increase, so if the AST-ALT ratio is more than 5, think of an extrahepatic cause. But all these are great rules of thumb, and I suggest you have a look at the BPAC reference. Right, after that short interlude into liver function tests, we're going to think about cirrhosis. What is the difference between macronodular and micronodular cirrhosis? There are two differences. The first difference is in the size of the nodules. If they're more than 1 centimeter, 10 millimeters in size, it's macronodular cirrhosis. The other thing is a time thing. So micronodular cirrhosis progresses to macronodular cirrhosis. Cirrhosis is the final common pathway for many chronic liver injuries, and it's hard when a person has a cirrhotic liver and no other clues to determine the cause of the cirrhosis. We need to look elsewhere for finding that cause. Hurrah for serology. So what is cirrhosis? It's the end point of hepatic fibrosis, where any surviving hepatocytes then undergo hyperplasia and increase in size, first as little nodules and then as big nodules. It disrupts the normal architecture, giving rise to portal hypertension. This is a picture of things that can go wrong in portal hypertension. So we have the varices on the surface of the abdomen, the expanded veins on the surface of the abdomen. We have the varices in the esophagus, and we have the enlarged spleen. Micronodular cirrhosis, less than 1 centimeter in size. Here they are. Down the microscope, small nodules, islands of surviving liver cells in this sea of fibrosis and inflammation. Macronodular cirrhosis, big nodules. Now, let's think about some new material. Here we go. We've moved on. I know that you have learnt a little bit about alcohol and non-alcoholic fatty liver disease, but no more NAFLD, right? We don't have NAFLD anymore. We have a new terminology. We have steatotic liver disease. So steatotic liver disease can be caused by alcohol or metabolic dysfunction or metabolic dysfunction plus alcohol, or we don't know why, cryptogenic. So non-alcoholic fatty liver disease is now metabolic associated steatotic liver disease, MASLD. Metabolic dysfunction associated steatotic liver disease. Why did they change it? Because they realized it wasn't just not alcohol, it actually had a positive association with metabolic dysfunction. Why change fatty to steatotic? I thought steatotic was a better descriptor. So now we have MASLD, metabolic dysfunction associated steatotic liver disease. If a person has metabolic dysfunction and excess alcohol, I am taking the opportunity to correct my slide there. METALD, metabolic and alcohol associated liver disease. And cryptogenic steatotic liver disease is where there's no cause found. So here we go. Here we have steatotic liver disease, which can either be just metabolic associated liver disease, MASLD. Now, if this becomes inflamed as well, it becomes MESH, metabolic dysfunction associated steatohepatitis. So the difference between this is there's just fat in the liver, and there's fat in the liver and inflammation. And we know that inflammation is bad for the liver. So that's the metabolic pathway. And then there's the alcohol-associated liver disease. Here we go. And then there's a combination. So many people have both a metabolic component and an alcohol component, and it is called METALD, and they're on a kind of scale, right? So you can have a combination of both of them that's alcohol predominant, or a combination of both of them that is metabolic predominant. A more nuanced interpretation of steatotic liver disease. And of course, there are other things that can cause steatotic liver disease, such as drugs or cryptogenic, we don't know. Carrying right along here. So we're trying to decide what kind of steatotic liver disease a person has. And the first question is, Do they meet any of the cardiometabolic criteria? In other words, could this be metabolic dysfunction associated liver disease? And here are the criteria. So we want someone who is heavier weight, has a high fasting serum glucose, high blood pressure, high triglycerides, low HDL, the good cholesterol, or the equivalent things here. Okay, so does the person meet any of the cardiometabolic criteria? Yes. Are there any other causes of steatosis? No. They have MASLD. Yes, they have MET-ALD, or just alcoholic liver disease, depending on how much alcohol and how metabolically abnormal they are. Does the patient meet any of the cardiometabolic criteria? No. Is there any other cause of steatosis? No, it's cryptogenic, or it might be another cause like alcoholic liver disease. So why am I going on about steatotic liver disease? That's because it is the world's most common liver disease. And the prevalence of steatotic liver disease in New Zealand is high, particularly among Maori and Pacific populations, and it often presents late. I believe it has its own BPAC article worth reading. We talked about the difference between metabolic abnormals, steatotic liver disease, MASLD, and metabolic associated steatohepatitis. So this is just a liver with lots of fat in it. This is a liver with lots of fat in it and some inflammation. We know that inflammation is bad for the liver. The fat can either be what we call macrovesicular, which is large drops, or microvesicular, which is small drops. Functionally, no difference between them. So here we go. What else do we see? Well, this is a type of acute liver injury. So we get things like ballooning degeneration of the cells, but in particular, we get the intermediate filaments that form cytoskeletal proteins. They clump together and form this Mallory hyaline, sometimes called Mallory dank bodies. Previously, I'm sure you've heard this associated with alcoholic liver disease. Well, it can happen in metabolic associated steatohepatitis as well. So we can't use that to tell the difference between them. The best way is actually to take an alcohol history. Here we go. So what happens if we have long-standing steatohepatitis? What happens is we get an increase in fibrosis. This is the central hepatic vein. This is a stain that shows up fibrous tissue, and we can see that there is an increase in fibrosis, forming this bridging fibrosis, just like people get in other kinds of chronic hepatitis. Then it goes to even more fibrosis, and then it goes to cirrhosis. So steatohepatitis can lead to cirrhosis. Here is another diagram. So someone with a healthy liver then develops, they haven't updated the terminology in this picture, metabolic MASLD, metabolic abnormal steatotic liver disease, which then becomes inflamed, then can go to cirrhosis, and then can develop all the complications of cirrhosis, like hepatocellular carcinoma. All right, there is a tool. You know I love tools online. So mdcalc.com, if you've not discovered it yet, is really helpful. So here's an exercise I'd like you to do. We do it live in class, but see if you can work out how likely this patient is to develop fibrosis of the liver. Okay, 59-year-old man who's overweight but not diabetic with these liver enzymes. Have a go. Have a go. Just pause the video and have a go. Okay, carrying right along. I hope you found out that he wasn't very likely to have fibrosis, because this is most middle-aged men, really. Okay, alcoholic liver disease. So alcoholic liver disease is another cause of steatohepatitis. If you have a normal liver and it experiences alcohol, it will immediately go into acute inflammation. Okay, liver cell necrosis, lots of inflammation in the parenchyma, Mallory bodies, fatty change. Either multiple attacks or chronic, not quite so acute exposure will lead to steatosis, and then steatohepatitis, and then cirrhosis. There's a wide variety of people who actually, there's a wide variety of risk for cirrhosis. Some people seem to be able to drink lots of alcohol and not get cirrhosis, and other people are relatively sensitive to it. And women are particularly sensitive to alcohol and getting cirrhosis. Okay, so here we go. So alcoholic liver disease, 80 grams, so this is 8 units, gives rise to reversible steatosis. But if you take 80 grams a day for prolonged periods, you get a risk of severe hepatic injury. Only 10% of alcoholics will get cirrhosis. Women, some ethnic groups, strong family association. So there's obviously some genes giving rise to a sensitivity there, but also comorbidity, people who have hepatitis C and drink alcohol, bad news, high risk of cirrhosis. Death due to hepatic coma, GI bleed, intercurrent infection, hepatorenal syndrome, hepatocellular carcinomas are all complications of chronic liver disease. Okay. Flicking through here, alcoholic hepatitis looks quite like steatohepatitis, doesn't it? They look very, very similar. You can see the Mallory's hyaline here. We've got some acute inflammatory cells pointed out here. Gives rise to a similar kind of fibrosis, that's the blue stuff, and micronodular, then macronodular cirrhosis. Let's try a multiple choice question. So here we go, problem representation. A 41-year-old man is jaundiced with an enlarged abdomen with a fluid wave, i.e. a 41-year-old man is jaundiced with ascites, has an enlarged liver. These are all American units, but basically he's got a low albumin, a high total bilirubin, a high AST and ALT. His ALK phos is okay, and his ammonia is a bit up. A liver biopsy formed demonstrates abundant Mallory hyaline. Okay, so we're looking at someone who has steatohepatitis and chronic liver injury. And what causes that? Well, we know that it's either going to be metabolic, alcoholic, or some combination of the two. And so here we go, alcoholic hepatitis. How would these be different? Well, they don't have steatosis in them, really, these. Diabetes on its own is part of the metabolic liver disease kind of spectrum, contributing to it, but isn't a diagnosis that you'd make from this history. So he might have diabetes. Okay, what next? We're going to talk about some genetic liver diseases here. So I'm just flicking through the things at the side. Find my place. Right, autoimmune hepatitis. Let's have a little think about autoimmune hepatitis before we think about metabolic liver disease. I don't have good slides for autoimmune hepatitis because it just looks like all the other chronic hepatitis. Autoimmune hepatitis will be covered, I believe, in your immunology lectures. And I also think it might be in the homework. But autoimmune hepatitis is a chronic hepatitis that is largely diagnosed by the spectrum of immunology, sorry, a spectrum of antibodies that is generated from serology and also in a combination with abnormal liver function tests. I should try and find out a bit more about it for you, I think, and might do a supplementary video. Okay, but let's move on because I think you might get more of that in immunology. Right, we're going to talk about alpha-1 antitrypsin deficiency. So trypsin is an enzyme which inhibits proteases. The proteases, so stearine proteases are common. They have important functions in killing organisms. Sometimes they can get a bit overexcited if they're not inhibited and start chewing up normal body structures. So in particular, alpha-1 antitrypsin inhibits neutrophil protease enzymes in the lung. So the neutrophil elastase in the lung, if not inhibited, will cause breakdown of the walls in the lung, i.e. emphysema. What activates it? Inflammation like pneumonia, infection like pneumonia, other inflammation, or smoking. So if a smoker has alpha-1 antitrypsin disease, they can activate their neutrophil elastase. It's not inhibited, and they will get emphysema at a very early age. It's an autosomal recessive disease, so won't obviously run in families, just pop up because the people who have who are heterozygous for it don't have symptoms unless they smoke, in which case they have an increased risk of emphysema at a later age. We know the mutation, you don't have to remember it, and there are lots of variants of the alpha-1 antitrypsin disease. These are classified into M alleles, which are kind of normal variants, and then other common variants, which are abnormal. So about 1 in 3,000 people has an abnormal alpha-1 antitrypsin function, alpha-1 antitrypsin deficiency, due to having 2 Z alleles, which means that alpha-1 antitrypsin doesn't work. So it's autosomal recessive, which means they have to be homozygous. How can it present alpha-1 antitrypsin disease? There are several ways. The first way it can present is it can present as neonatal hepatitis, or it can be silent until adulthood when it presents with cirrhosis or pulmonary emphysema. Characteristically, we look down the microscope at it, and we do a stain, the PAS stain, and it shows up as these PAS positive blobs. These are alpha-1 antitrypsin proteins that aren't able to be exported by the liver because they're abnormal, and they accumulate. Now, this accumulation activates those stellate cells and causes ongoing fibrosis and apoptosis of liver cells. So eventually it leads to cirrhosis. Okay. So this is a real funny slide here. Let's just get rid of this. No, I've done the wrong thing. Okay. I'm not quite sure how to get rid of that click to add title thing like this. There we go. That was really annoying. We'll move it back now. All right. So heterozygotes are carriers of the disease. They produce lower levels of alpha-1 antitrypsin than normal. There is a slight increase of liver and lung disease in people who are heterozygous, but it usually needs a cofactor to activate the disease. So an alcoholic with alpha-1 antitrypsin disease is more likely to get cirrhosis. A heavy smoker with alpha-1 antitrypsin heterozygous is more likely to get emphysema. Okay. So it tends to be a cofactor if they've got other insults to their lungs and liver. So here's a thought. Should alpha-1 antitrypsin disease, 1 in 3,000, be included in the newborn screening tests? This is a discussion point. If you're in class with me, we'd have a discussion about this. If you're not in class with me listening to this video, think about what tests are in the screening tests, whether or not they can, whether or not intervention is helpful for them, and the age of disease onset. Should it be included in the newborn screening test? I think. The next disease that we are going to think about is Wilson's disease. So this is much, much less common, quite common in multiple choice questions. It is, again, caused by a known mutation, and Wilson's disease has impaired copper excretion into bile. Okay, so just if you remember anything, remember this. Wilson's disease has impaired copper excretion into bile, and it means that toxic levels of copper rise in many tissues, in particular the liver, the brain, and the eye. Here is some extra for experts, those of you who have done a molecular pathology, molecular medicine or something before, can read this. Otherwise, everyone else, Wilson's, impaired copper excretion, toxic levels of copper. People present with acute to chronic liver disease, Parkinson's disease. We know they've got Wilson's disease without doing a genetic test, because this ceruloplasmin can be measured in the serum. Most people are compound heterozygotes. So what does that mean? It means that they have alleles in the gene that are both slightly non-functional, giving rise to an overall non-functionalness. And there's a wide variety of alleles, so it's quite difficult to design a PCR test for them. And we would have to sequence the genes, recognize that they were variants of, that they were pathological variants. It's much easier to measure the ceruloplasmin and know that functionally this person has a poor copper metabolism. Here we go, classic pictures of Wilson's disease. So the Kaiser-Flasher ring is a classic picture that is just like one of the classics in medicine. And what we see in the liver is kind of this browny copper pigment, which we can measure on a liver biopsy. So tell me, do you think Wilson's disease should be included in the newborn screening tests? Heel prick, 1 in 30,000. Is there any treatment for it? And is it worth intervening early? Worth a thought. Okay, let's think of iron overload now. So iron overload can be divided into two categories. There's the non-genetic iron overload from just taking in too much iron. And then there's the hereditary hemochromatosis. So hereditary hemochromatosis, there's a defect in iron absorption, doesn't get shut off when the iron stores are full. And in hemosiderosis, there's just massive overload of intake, like transfusions, thalassemia because of ineffective hemopoiesis, alcoholic liver disease, where people are drinking iron-containing beverages, brewed acidic brews in iron pots were the classic one. The liver looks different in non-genetic iron overload, and it has different implications for outcome. So in non-genetic iron overload, i.e. too much intake, the Kupffer cells, those macrophages, take up the iron. This is a stain called the Pearl stain, and it's staining these macrophages blue. The macrophages, they stay happily there in the sinusoids, and they do not cause the stellate cells to proliferate. And so it does not cause cirrhosis of the liver. In genetic hemochromatosis, the iron accumulates here inside the liver cells themselves. It does activate the stellate cells and does cause fibrosis of the liver. Here we go. Here is a set of information about genetic hemochromatosis. What are the important bits? The first is that it's often silent until the 6th decade. It has a classic picture of cirrhosis, diabetes because it damages the islet cells in the pancreas, and skin pigmentation. Affects men more than women. Women have natural iron shedding ability, and so they accumulate less iron than men. It is more common in the European population, where there is a specific mutation that we can test for. Look, 11% of European populations carry the gene, 11%. but they're heterozygotes, and so they don't show the disease. The disease only occurs when people have a homozygous, two abnormal copies. So that is 0.5%, that's 1 in 200 people will have genetic hemochromatosis. It causes cirrhosis. We recognize it because we stain for the iron, and there it is. It can be a precursor for hepatocellular carcinoma. Okay, nearly there. So we've done this so far. I might have to give you a bit more on autoimmune hepatitis. But we're now on to diseases of the bile duct. Cholestatic liver disease. So what is cholestasis? So it's a marked reduction in bile secretion. It can arise from, as I've said, right up the hepatic end, the hepatic parenchyma, where we can have secretory disturbance from the hepatocytes or obstruction from any level from the canaliculi down to the duodenum. We can try and define intrahepatic and extrahepatic cholestasis, but often it's mixed. This is what cholestatic liver disease looks like. The most common cause is drugs and medicines. So here we go. What it looks like is we get these bile plugs. This is in the bile ducts, and we get little bile ducts between bile plugs between the liver cells. And it can be associated with inflammation and then fibrosis and then cirrhosis. But usually with medicines, of course, we stop taking the medicine, that goes away. So that's the first thing, cholestatic liver disease. So sometimes bile ducts disappear or are not formed properly. Vanishing bile duct disease. So some neonates are born with biliary atresia. This means their normal common bile duct or hepatic duct does not form properly, and so they can't excrete bile. They become very sick and need to have a operation to restore the patency of the bile ducts. In adults, stuff can make bile ducts disappear. What stuff can make bile ducts disappear? Well, the most common one is primary biliary cirrhosis. So this is another autoimmune disease of the liver, like autoimmune hepatitis. And then there's primary sclerosing cholangitis, which is related complication of ulcerative colitis. And then there's some rare ones to do with lymphocytes attacking the ducts as part of rejection. Let's think of primary biliary cirrhosis. So we have a typical presentation: itching, jaundice, fatigue, and right upper quadrant pain. We have a typical serology, right? So primary biliary cirrhosis is defined by anti-mitochondrial antibodies, and it causes inflammation and destruction of small bile duct. So early on, what we get is inflammation around the bile ducts in the liver, affecting the small bile ducts in the liver, destruction of the bile duct, here the bile duct, and a granulomatous inflammation. So a type 4 immune reaction caused by anti-mitochondrial antibodies makes the ducts disappear and causes cirrhosis with absent bile ducts. All the bile continues to accumulate in the liver and turns the liver green. The number 2 disease, primary sclerosing cholangitis. All right. So as well as the small liver ducts, we've got both intra and hepatic bile ducts that are fibrosed, mainly in men, mainly associated with ulcerative colitis. Less inflammation here. It's just activation of fibrosis more, and the fibroblasts spin around the bile duct, giving this characteristic picture of onion skin fibrosis. And its complications are cholangiocarcinoma and also biliary cirrhosis, because the bile ducts get destroyed, bile accumulates and causes inflammation. Here's a picture of it. So this is what I was meaning by this bile duct cirrhosis, bile duct onion skinning with the fibrosis around it, not so much inflammation, both intrahepatic and extrahepatic bile ducts. A very typical picture on an ERCP. Our last topic for today, I think, is liver nodules and tumors. So in the liver, there are benign and malignant tumors. I see an awful lot of hemangiomas in the liver when I go to MDMs, and they do CT abdomen, and they're just there. There are so many of them. What is a hemangioma? It's like a benign blood flake, yeah, benign expansion of a blood vessel or a cluster of blood vessels in the liver. So this is showing a sequence where we've got the contrast going through, and it collects in that hemangioma, and the radiologists are able to describe them quite confidently. Here we have one macroscopically, and microscopically they are dilated thin-walled blood vessels, as hemangiomas are anywhere in the body. So this is the most common liver tumor that you will see in about 1 in 10 CT scans. Then we have liver cell adenoma. So by its name, it implies that it is a overgrowth of liver parenchymal cells, and that's what it is. Often seen in young women on oral contraceptives. The problem is that they can rupture with life-threatening intraperitoneal hemorrhage. This particularly happens during pregnancy. This is what they look like, this kind of nondescript brown nodule that exists in the liver. And they're also found in men who take steroids for bodybuilding. And then there's liver cancer. So there's 2 kinds of liver cancer. The first kind of liver cancer is hepatocellular carcinoma, which arises from the liver parenchyma cells, is associated with cirrhosis, and also associated in particular with hepatitis B. So it's a very common cancer, the 3rd most common cancer on a worldwide basis, because of all the maternal fetal transmission of hepatitis B in less developed countries. So chronic hepatitis B and C infection in countries through Asia and Africa give rise to a high hepatocellular carcinoma incidence. We've had an increase recently due to hepatitis C virus infection, which has been rising in Western countries, probably stabilized now because we can treat hepatitis C more effectively. Okay. So hepatocellular carcinoma is associated with anything that causes cirrhosis, any of these that cause cirrhosis. But in particular, it's associated with hepatitis B and C. It occurs in mostly cirrhotic livers and presents with the triad of upper abdominal pain, ascites, and enlarged liver. You can feel the irregular rocky liver, and it has characteristic abnormalities in its liver enzyme. In particular, I draw your attention to this. It has raised alpha-fetoprotein. So alpha-fetoprotein is an oncogene marker that is raised most commonly in 3 situations. First, it's normally raised in newborns. It's raised in men with testicular teratomas, and it's raised in liver cancer. Mostly the diagnosis is by imaging, but we can do biopsies if we want to diagnose it. Here are some examples. This is a normal liver with hepatocellular carcinoma in it, forming a large mass. This is a liver with cirrhosis in it. We can't really see very well the hepatocellular carcinoma because it's hidden. So actually all these pale bits, hepatocellular carcinoma, they are cirrhosis. It's spreading through the liver, but it is a cirrhotic liver. Sometimes they're green because they produce bile. What do they look like down the microscope? Well, they look like a slightly deranged normal liver. Okay, so if you look carefully, these trabeculae in this cancer are too wide. These cells are too pleomorphic. This one is producing bile, which of course has got nowhere to go because the liver isn't producing bile ducts. All right, hepatocellular carcinoma has a poor survival rate unless it can be effectively resected in low stage disease. There's one other primary tumor of the liver, and that is cholangiocarcinoma. It's pretty much exactly the same as cholangiocarcinoma that I talked about when I was talking about the gallbladder and pancreatic duct. The liver loves metastatic tumors. It's the most common malignant mass in the liver, and they come from large bowel because of the portal circulation, but also other places as well. How do we tell the difference between a metastatic and a primary carcinoma? Well, clinical history is really good. Someone's had a history of colonic carcinoma and then develops a liver mass and they don't have cirrhosis or hepatitis. This would strongly suggest that this is a metastasis. If a person has numerous nodules, then this is more likely to be a metastasis. Here, someone's had a history of melanoma and a normal liver, so this is likely to be a metastasis. Here we are having normal metastatic liver cancer. Sorry, here we're having a normal liver with metastatic colon cancer in it. Numerous nodules equals metastasis. Sometimes you can get numerous hemangiomas, but of course, putting some contrast in will be very helpful for that. Okay, sometimes if the metastatic cancer is confined to one part of the liver, for example, segment 7, for example, it can be taken out and the patient can have extended life, because sometimes colon cancer just has one big metastasis rather than the scattershot metastases that are characteristic of, for example, breast carcinoma. And that brings us here back to the end, where we have learned about all these diseases. Extra for experts is going to be autoimmune hepatitis. And I do have some homework for you where there's a series of multi-choice questions and then one case to go through. Thank you.